A very warm good afternoon to all. Without wasting much of time, I will get on to the abstracts that has been given to me in triple negative breast cancer. The first one was presented in ESMO Congress 2023 this year. This is a population-based cohort study which looked at the real-world outcomes of ER0 versus the ER-low patients from Sweden. In 2010, the ASCO-CAP came out with the first guidelines which normalized the ER positivity rating, and they had lowered the cutoff from the 10% to 1%. Up until then, there were many studies which were looking at various percentages, and Sweden continued to treat this ER low, that is ER positivity of 1 to 9% as triple negative breast cancer. There are several studies which have shown that the ER low HER2 negative breast cancer behave like TNBC and they are similar to them. There are similar pathological and molecular characteristics as well as in the terms of treatment outcomes, they seem to be similar. So the debate as to whether the endocrine therapy is beneficial in them and whether to consider them separately from triple negative breast cancer still holds. So this is a population-based cohort study which was done by including the patients who were treated as triple negative breast cancer between the years 2008 to 2020, taken from the Swedish National Cancer Registry. The primary endpoint was to look at the overall survival and the distant disease-free survival in these patients, comparing between the ER0 versus the ER-low group. They started off with more than 8,000 triple negative breast cancer patients, and after excluding the patients who didn't have data on the percentage of ER positive cells, also after excluding the patients who had a primary metastatic disease or not, those who were not operated, the final study population consisted of 5,657 patients. Coming to the results, the ER0 group was 90.1%, that is 5,097 patients, as compared to 560 patients or 9.9% for the ER low group. And if you look at the grade, similar to the ER0 group, the ER low group had a higher grade 3 patients, but this number overall was lesser as compared to the ER0 group, 69.4% compared to 80.8%. Also in terms of Ki67, the mean and the median Ki67, the number was overall lower as compared to the ER0 group. In terms of histology, the lobular histology had a proportional higher number in the ER low group, that is 6.8% as compared to 1.6%. Coming to the treatment characteristics, there were no differences between the two groups with regards to surgery, the type of surgery done, the chemotherapy received or the radiotherapy. In fact, even PAT-CR was similar, 25.1% in the ER0 group versus the 28.1% in the ER low group. Overall, the overall survival, which was the primary endpoint, was somewhat better in the ER low group with a hazard ratio of 0.83. The p-value was just significant, borderline significant, 0.051. The distant disease-free survival did not differ. On multivariate analysis, looking at the risk factors that predicted OS, the stage, age, grade, and the receipt of chemotherapy affected the OS, but the ER status of 0% versus the low group did not affect. So the author conclusions were that the characteristics and prognosis of this ER low breast cancer is similar to the ER0 group, which when treated as triple negative breast cancer, and it signifies or underlines the findings of previous studies. More than 10% threshold seems reasonable to consider them as ER positive. So discussion take home is that this study reinforces that there is a growing evidence of similarity between these two groups, the ER low group versus the TNBC. So when it comes to the clinical practice in the curative setting, when we are deciding upon the chemotherapy, especially adjuvant, we should probably take them as triple negative and then lean towards chemotherapy. But when deciding on the adjuvant endocrine therapy, we should still proceed with giving endocrine therapy in them for whatever possible benefit is there. In the metastatic setting, it is possibly better to treat them with chemotherapy first. In terms of newer therapies like endocrine, immunotherapy and the antibody drug conjugates, there is still more data to be generated in this group, and the further trials of triple negative breast cancer should be including this group of ER low. Coming to the second study, which was published in Scientific Reports by Dr. Shona Naik et al., looking at the risk factors for the development of triple negative breast cancer versus non-triple negative breast cancer, which was a case control study. So from epidemiological studies, we know that smoking, alcohol consumption, high-fat diet, reproductive and socioeconomic factors are associated with breast cancer. But when we look at the individual breast cancer subtypes, we have not got an idea about which risk factors are predicting for this specific subtypes. If you look at the ER negative subtype, there are some studies which suggest that higher parity and a younger age at first childbirth probably associates with the ER negative subtype. In terms of studies from India, it has been shown that proportion of patients in the triple negative breast cancer is higher, 25 to 30% are the triple negative breast cancer group. So this was a prospective case control study where cases were triple negative breast cancer, whereas controls were all other breast cancer groups. And this has to be kept in mind that the controls were not normal patients, but other breast cancer groups, which were not triple negative breast cancer. The study included patients between the age of 18 to 70 treated with curative intent. No metastatic disease was allowed and no prior therapy was allowed except for surgery. It was conducted in Mumbai and Pune. Study procedure consisted of collecting a detailed questionnaire which was validated at baseline, looking at the risk factors. Clinical pathological parameters were collected, and statistical analysis was done to look at the association of risk factors between the two groups in terms of odds ratio, which was calculated by unconditional logistic regression analysis. A sample size of 1,000 was estimated, assuming that there is a risk factor incidence of 15%, and we would get a association of odds ratio of 1.65. So coming to the results, between July 2011 to December 2014, 912 patients included, median age of 47. We see that the triple negative group is quite higher, 29% as compared to the Western world. Overall, the ER positive group or the HER2 group, ER positive group was 43% in this study. When we look at the individual risk factors on univariate analysis, none of the reproductive factors like parity, age at first childbirth or breastfeeding were significant. Even body size factor of BMI was not found to be significant. In terms of body size related factors, the only two factors which came out to be somewhat significant, and that too of borderline significance, was lesser waist circumference and a lower waist to hip ratio. This is for triple negative breast cancer compared to other breast cancers. None of the habits came out to be significant. In lower socioeconomic status came out to be borderline significant. If you look at the multivariate logistic regression, no factor was found to be significantly associated. This is the table looking at the odds ratio and the significance. The ones highlighted in red are the body weight significant factors which came out to be significant, and the one in green is the socioeconomic status, which is of borderline significance. So the author conclusions are that a lower waist to hip ratio and a lower socioeconomic status could be differentially associated with TNBC. A differential association of TNBC as compared to other types of breast cancer. Most reproductive and non-reproductive risk factors showed no significant association. So in terms of population-based interventions, a broad risk factor modification strategy should be selected rather than specifically tailoring them for the breast cancer subsets. So this was a sufficiently large study from India, prospective study, which shows that triple negative breast cancer constitutes a higher proportion of patients, and it looked at the preferential association of risk factors. So overall, although we would say that a higher waist to hip ratio is associated with breast cancer as a whole, but in this study it was showing that for triple negative, the lower waist to hip ratio had an association, but this was in comparison with the other breast cancer types, which would include a more of ER positive type. So also in terms of body weight related factors, rather than BMI, a waist to hip ratio seems to be a better descriptor for this metabolic predisposition. Thank you.